Dr. Ragini ma'am, I think we can start.
Parikshit sir, you are giving the welcome note.
Yeah, okay, I thought it was okay. On behalf of the Maharashtra Ophthalmology Society, I would like to welcome all of you for this webinar on newer IOL technologies organized by the Nasik Ophthalmology Association. Without much ado, I will hand over to our learned chairperson, scientific committee, Professor Ragini Parikh, to again start the honors, and Dr. Atul Sonamne, my friend from Nashik, who's the president of NOA, who has presided over this. Over to you, Dr. Ragini.
Thank you. Good evening, everybody. So we welcome you to this series of the CMEs that we've been holding on Zoom. Today, we are going to discuss about the recent technologies in the new developments of intraocular lenses. We have with us a fantastic panel of Dr. Sujata Mohan. She's a very, very renowned surgeon. She has got the Nari Shakti Puraskar by the Honorable President of Maharashtra. She received various awards as a COVID warrior. We have Dr. Ajit Hazari, our own Dr. Ajit Hazari. We have with us Dr. Suresh Pandey sir, who is going to be with us as a panel. We have with us Dr. Sharad Patil sir, Dr. Manish Bapaye, Dr. Vaishal Kenya, and Dr. Nitin Deshpande, who will be speaking. And we will have a fantastic panel discussion on what. This meeting is hosted by the Nasik Ophthalmological Society, and Dr. Atul Sonamne and Dr. Kalyan have done a fantastic job of arranging everything. We have with us my mentor, Professor Sunaina Malik, madam, who is one of the advisors of the MOS also. I request Dr. Parikshit Gopte sir and a beautiful team of the chairman, co-chairman, including Dr. Shubhangi Pimprikar, Dr. Swati Zamwar, who have made this program possible, Sirish Thorat, Dr. Pankaj Shah, the dynamic, and Swapnesh, the dynamic trio, who's a beautiful team. Good evening, Dr. Anil Kulkarni sir, our mentor and guru. And I hand over to Dr. Parikshit Bhai to introduce Dr. Atul Sonamne, who is the president. And then from there, we hand over the whole program to Dr. Atul Sonamne, who I'm sure will conduct the program very, very beautifully. Thank you, sir.
Yeah, I think Dr. Atul, who's a friend since BJ Medical College days, and this year is very special because Nashik Ophthalmology Association is also organizing the MOSCON. So last year's MOSCON could not be done because of COVID, but they have been preparing for this way back since 2018. And I'm sure it will be a wonderful thing in Dr. Atul's tenure. So over to you, Dr. Atul. Please take over charge and we start with this program.
Thank you. Can I just interrupt? I forgot to introduce one of the panelists. He, of course, needs no introduction, Dr. Aditya Kelkar. Yeah. He is my brother because Dr. Kelkar sir is our guru and we work together. We start the OT in the BOA and so we are the starting batsmen. So thank you, Aditya, for being with us. Dr. Atul.
Good evening, madam. Thank you. Thank you.
I request Dr. Sonamne sir to introduce the co-panelists.
Dr. Atul.
Either Dr. Swati or Dr. Atul can introduce the co-panelists.
You can just do a verbal introduction.
Yeah.
Atul sir, you can unmute yourself, sir.
Yeah.
I welcome President MOS Dr. Parikshit Gopte sir, Chairman Scientific Committee, Dr. Ragini Parikh ma'am, and Secretary Dr. Swapnesh Sawant sir for this webinar. I welcome you all to this MOS NOA webinar on recent advances in IOL technology, along with my team of co-chairman Dr. Shubhangi Pimprikar ma'am, co-convener Dr. Swati Zawar ma'am, and especially our moderator and secretary Dr. Kalyan Sothe, who has put in lot of effort since last 1 month, coming up with such a comprehensive program for the webinar with the eminent group of speakers, Dr. Kenya, Dr. Deshpande, Dr. Sharad Patil sir, and Dr. Manish Bapai. and panelists Dr. Sujata Mohan ma'am, Dr. Suresh Pandey sir, Dr. Ajit Hazari sir, and Dr. Aditya Kelkar. I now request Dr. Kalyan to carry forward the proceedings.
We shall get on to the first presentation. So I request Dr. Kenya sir to please load his presentation and start screen sharing. On behalf of NOA, I welcome and thank all the MOS team for such a wonderful program. So I'll be introducing Dr. Vaishal Kenya sir. He is our first speaker for today's webinar. Dr. Vaishal Kenya sir is a cataract, cornea, refractive and glaucoma surgeon with special interest in corneal biologics. He is the first in Maharashtra to introduce femto laser. He is the first ophthalmologist in India to implant Envista glistening-free IOL and first ophthalmologist in India to implant Lucidius toric IOLs. He's been awarded with the Young Ophthalmologist Award 2017 at Star Evo ICL Award function at Lisbon, Portugal on 5th October 17. His videos submitted at ESCRS in Video Symposium on challenging cases got selected consecutively for 3 years in year 2018, 19 and 2020. And he had a recent publication on association between corneal biomechanics parameters and myopic refractive errors in young Indian individuals, which got published in Taiwan Journal of Optometry in March 2020. And age-related variations in corneal biomechanical parameters in healthy Indians, which were published in our own IGO in November 2020. So over to you, sir. Dr. Kenya, sir, please start your presentation.
At the outset, I thank the MOS and the NOA and especially Dr. Atul Sonawne sir and Dr. Kalyan Chaute sir for inviting me and giving me this opportunity today to talk on Lucidius, a non-diffractive hybrid EDOF, a way to go. So advancement in lifestyles and demanding patients always ask us that after cataract surgery, we would not like spectacles. The hunt for an ideal IOL is on, and we are moving in that journey towards an ideal IOL. Extended depth of focus IOL is one of the milestones in this journey. And today we will discuss various premium IOLs today. And I'm sure at the end of all these talks, we would have very distinct, clear things in mind and points to take home, which is better and which is not. So extended depth of focus IOLs provide better quality of vision, better contrast, better nighttime vision, and do not have any glare or scattering of light because they are devoid. With the new generation extended depth of focus IOLs are devoid of rings. So extended depth of focus lenses can be divided as pure EDOFs or hybrid EDOFs. Spherical aberration based EDOFs and EDOFs utilizing the pinhole effect. And now hybrid multifocal and diffractive EDOFs, which the Symphony was the first EDOF which came to our knowledge, and then on there were many EDOFs coming in. The EDOF family had to use a hybrid platform so that they could target the near vision which was poor in the earlier generation of EDOFs. The first generation of EDOFs had rings. They had halos and glare, but the next generation were without rings, so that the glare and the nighttime vision was much better and the contrast sensitivity was much better. Now, the EDOFs without rings, the first generation would be the iHance and the Vivity lens, which is to come in the near future. The second generation were EDOFs without rings, but able to see all distances. Now, this was definitely a distinct advantage to the previous generation EDOFs, where the predominant vision was more distant vision and intermediate vision. Now, EDOFs by diffraction had a very tight focal points, which caused a depth of focus, but they had lower light intensity. and they had dysphotopsia. EDOFs with spherical aberration, definitely the light intensity was lower, the amount of image quality also was lower, and near vision was also not that good. So EDOF by pseudo non-diffractive beam. Now to understand what is diffraction and what is non-diffraction. Diffraction means any obstruction in the beam path causes divergence of the beam or splitting of the light. Now with a pseudo non-diffractive beam, we do not have any rings to cause any obstruction. So there is no glare, halos, and the propagation of light is done with a new technology which is patented, and we will shortly discuss more about that. So an EDOF with a pseudo non-diffractive beam has in the central 1 millimeters of its optic a conical shaped hyper aspheric optics, which is known in technical terms or in optical language as an axicon. Now this axicon is nothing but causes pseudo non-diffractive beam, where because of constructive wavefront interference, there is an increased extended depth of focus. So the main optical property is an aspheric central part of the lens behaving similarly to an axicon, transmitting what is known as a bezel-like ray. So this bezel-like ray does not have any the diffraction occurring. So there is no loss of light, which is very, very important. So the intensity of light is far superior, as well as there is no glare and halos, as well as there is no loss of light. So the nighttime vision is far better. So the Lucidius lens design has a central lenticule which has this axicon of 1 millimeters. The rest of the optics of 6 millimeters, that means the 5 millimeters rest of the optics is a refractive surface for far vision. So I just wanted to bring out one point between the spherical aberration versus pseudo non-diffractive beam. The depth of focus which you see, the amount of depth of focus is far, far greater than a spherical aberration created EDOF, where the depth of focus range is much smaller. So technically the light intensity is far better and the range of focus is far better. So we did a retrospective study in January 2020 to March 2020 with a sample size of 48 eyes, where a comprehensive preoperative assessment was done. A comprehensive surgical planning was done with the IOL Master 700 and a Virion image guided system. And exclusion criteria were all comorbidity eyes were excluded, where Lucidius was not implanted. And I was the sole surgeon. We did a clear corneal temporal incision with a capsular axis of 5.5 and hydroimplantation of this EDOF was done in the bag. Immediate post-op follow-up was at 12 hours. Vision slit lamp non-contact tonometry was done. And this was the post-op regime, which was pretty standard. Steroids, non-steroidals, antibiotics, lubricating drops, and systemic antibiotics were given. So outcome variables were measured at 1 month plus or minus 7 days. We measured the distant vision on the Snellen's chart. N notation at 40 centimeters and 80 centimeters was noted. The spherical equivalent refractive error was noted, was calculated, and the internal higher order aberration for a 6 millimeter fixed pupil was seen. So overall data of 48 eyes, 5 eyes were excluded due to missing data and history of ocular coma was excluded. So this is my preoperative data of eyes. The exit length was pretty emmetropic, as well as the K values are pretty emmetropic. So we showed an uncorrected distant visual acuity in almost 87.76% was 6/6 and around 12.24% 6/9. Intermediate vision at 80 centimeters was measured. In majority of them, we could achieve N10 and in some patients also N8 and N6 vision. So in majority of them, uncorrected near visual acuity, which was most important for this lens, because this was setting it apart from the rest of the EDOF series. Here, the near vision of uncorrected was in 87.76% N6. Binocular uncorrected vision, 100% of them were 6x6. The intermediate vision was also binocularly N10 in all the patients. Near visual acuity in 100% was N6. So distribution of refractive error, which I feel is a key. The hitting the emetropia or near emetropia is the key, and controlling the cylindrical power is the key, unlike the previous generation EDOFs. Role of higher order aberration, what I wanted to point out is this lens has a total spherical aberration of 0.14 and a negative spherical aberration of just minus 0.1. So this is a near neutral EDOF. So most of the generation of the depth of focus is because of the hexagon optics and not because of spherical aberration. If you see the total higher order aberration is marginally high, it's around 0.54. A study on the modulation transfer function and contrast sensitivity was quite good. It showed in photopic conditions of almost was found to be around 0.6, which is equivalent to a monofocal lens. So with Lucidius, most of the patient achieved excellent visual acuity for all distances, and there was no positive dysphotopsia nor negative dysphotopsia, which was very, very important. And there were patients who had a residue who were uncorrected 6/9 improved to 6x6, showing that it was the residual error which was contributing to the decrease in the vision. Angle alpha and angle kappa did not matter because these are ring-free, non-diffractive IOLs. So in this lenses, the angle kappa and alpha do not matter. Binocular summation is definitely observed in all these patients. So there is a summating effect and it enhances the distance near and intermediate distance. Neuroadaptation is not required, unlike a multifocal IOL, and not even a mix and match or a micro monovision has to be attempted in this particular lens. So to conclude, this Lucidius IOL has an ability to see clearly continuously at all distances, causes no photopsia, tolerant to high angle alpha and kappa, ability to work in low light as good contrast sensitivity in light distribution. I'll shortly share a video of my Lucidius toric IOL implantation. You can see the slow unfolding of the lens, and easily you can implant this. This is a hydrophilic lens, and I have a 1 year follow-up of patients, but I have yet to YAG laser any of my patients. Thank you so much.
Thank you so much, sir. Thank you for that excellent presentation. Now we'll be listening expert comments from Dr. Sujata Mohan. She's the recipient of highest civilian award, Nari Shakti Puraskar. She got in 2018. She is Associate Medical Director of Rajan Eye Care Hospital and Director of Rotary Rajan Eye Bank. She has performed more than 50,000 refractive surgeries, 80,000 intraocular lens implantation surgeries, and over 7,000 corneal transplant surgeries. So it's huge. Presented more than 150 papers in national and international conferences, conducted over 100 CME programs, and conducted over 500 eye cams under the aegis of Blind Free India project launched by Chennai Vision Charitable Trust. Was adjudged one of the top women ophthalmologists in the country in year 2009 by a survey in Ophthalmology World Report. She was awarded the T. Agrawal Gold Medal for Best Woman Refractive Surgeon by Srimati Sheila Dikshit, Chief Minister of New Delhi in 2010. She was awarded the Best Video in Refractive Surgery category in APA-CRS in 2012 and got G. Sita Lakshmi Gift of Sight Award from Lions Club International Helen Keller Remembrance in Remembrance Day 2017. She was awarded Nataraja Pillai Best Paper Award at Shankar Netralaya Alumni Meet in 2018. So over to you, madam. We are eager to listen expert comments from you about Lucidius.
Thanks a lot for the wonderful introduction. At the outset, I'd like to thank MOS and as well as the Nashik Ophthalmic Society for giving me this opportunity to be part of this wonderful webinar. I have listened to Dr. Kenia's talk several times, and every time he gives a new insight into this intraocular lenses. I've been using these lenses for over a year now, and even before the pre-COVID era, we just started implanting these lenses, and so we also have about a year follow-up on these lenses. So to go from his last slide, I would emphasize the advantage of these lenses are the very easy implantation, and also the cartridge is very easy to load, and it doesn't need any special technique, and it can be very easily implanted. It slides in beautifully into the bag. And the other advantage of this lens is because of the design, the closed loop design, it is very well centered, which is very, very important for any multifocal or an EDOF lens. So because it occupies almost the entire bag, it centers very well. And the square edge design is probably the reason why we have a very low rate of PCO. In my series, I've hardly seen any PCO. So over these over this past few months, we've implanted about 30 patients with a follow-up of about 3 months. And the most important thing is that patients are very happy. See, that is the happiness score is very high. There's no complaint regarding distant vision, though this distant vision may be binocularly only 6.9 or 6.6, because the advantage is the intermediate vision is excellent as well as the near vision. So that is what I find is the greatest advantage. The other advantage also, I think, emphasized by Dr. Vishal Kenia was that the incidence of dysphotopsia is almost nil. What we do is that all patients who are undergoing multifocals or EDOF lenses, we put them through, or any premium lens, we go through a nitrate. So patients who have already got pre-existing problems, who have corneal surface problems, we do not encourage these patients to go in for multifocal IOLs, because these patients can definitely give rise to problems later. So post-operatively also we put them through eye trace to see what is the amount of aberrations which are arising from the internal optics. And we find in these patients there is hardly any internal optic aberration. And once the ocular surface is good, you get an excellent quality of vision for near distance as well as for intermediate vision. So that way it works very well. I think the science behind it has been explained beautifully by Dr. Vishal Kenia. And what I like about it mostly is I really don't have to worry about whether the patient drives a lot, because there's hardly any dysphotopsia or glare, or not any of my patients are complaining about this. So almost all patients who want a multifocal or EDOF lens, or patients who are doing a lot of computer work, are definitely good candidates for this lenses. So I would definitely when you given the choice of the different multifocals and EDOF lenses which are available today, I would give my first choice to these Lucidius lenses. And over a period of, these last 3 months, I've become a real big fan of these lenses. So I would definitely recommend people who have not been using them, you should start using them, and recommend very strongly to try out these lenses and compare them with the other EDOF lenses which we have been using for the past few years. And I think with these few words, I'd like to conclude, and thank you once again for the opportunity.
Thank you so very much, ma'am, for that excellent expert comments. I'm sure that most of our delegates will definitely start using these lenses with so much of knowledge and insight given by you. So thank you both for speaker and expert for excellent comments and being in keeping the time. Thank you so very much. So I will now request
Dr. Kalyan,
our co-chairman.
Dr. Kalyan, Dr. Ragini madam has requested that we can have quick comments from the other panelists also in between. Just half a minute or 1 minute comment, because we have all stalwarts with us. Dr. Sharath Patil sir is also there. So if anybody else also wants to comment on this particular lens, she has invited everybody to comment because we are on time.
Yeah, I invite our eminent panelists, Dr. Sharath Patil sir or Dr. Suresh Pandey sir and Dr. Ajit Hazari sir to add a few words about this. If they have any comments, you're welcome, sir. We are eager to listen. Please, sir.
Learn. I don't have much experience with this lens because I'm yet to use this lens. So maybe in the future, I'll be able to comment upon it. But currently, I'm not using this lens.
Yes, sir.
Okay.
Yes. I want to emphasize that I have used a couple of Lucidius lens. This is one of the most forgiving lens, or one of the lens which provides excellent near and intermediate vision, and patients are very satisfied with this lens. And I also have opportunity to use MinIOL implant, and both Lucidius and MinIOL implant, in my experience, the patients are very happy, very satisfied, and the near vision and intermediate vision is excellent, and with the minimal to no glare and haloge, and the happiness score is very high. So I think this is one of the exciting lens for the future. Thank you.
Comments from Hazari sir. Dr. Aditya Kelkar sir, please.
The follow-up period for these lenses has been just up to a year in both the series that we heard about. And my main reservation would be that it's a hydrophilic lens.
Hydrophilic.
So we would expect PCO within around 1.5 to 2 years, which is, I feel, is not acceptable in this category of patients. So, but other than that, I think the EDOF lens has distinct advantages for people who are not suitable for multifocal IOLs. That's all.
I request Dr. Aditya Kelkar sir to please have his expert comments on this.
Yeah, platform. I have not used this lens in particular, but I have used a Symphony, which is probably more or less on similar lines. And yes, it does give exciting results, especially in patients who are driving and are in working population, especially those who are working in front of the computers. Their intermediate vision seems to be excellent.
Thank you.
Patients are very happy with Symphony.
Thank you so very much, sir. Okay, so now,
yeah, we can move on. With
the permission of the chair and the experts, I will now request our co-chairman, Dr. Mrs. Shubhangi Pimprikar ma'am, to please introduce our very own senior surgeon, teacher, and the inspiration, Dr. Sharath Patil sir, who will be giving his talk on trifocals. So I request Dr. Patil sir to please load his presentation and start screen sharing.
Good evening, everyone. This is a great honor to introduce my mentor, Dr. Sharath Patil sir. Sir is an alumnus of Government Medical College, Nagpur. He started his private practice in 1987, and he works for the underprivileged through Kalpataru Alliance Eye Hospital. This work of his in the community ophthalmology was appreciated by giving him Eye Care Award on Helen Keller Day in 2015. Sir is doing all lamellar surgeries in a skillful way, and also has received G. Shantalakshmi Award by Shankar Netralaya for the same in 2015. He's received a BA award in 2012. In spite of his busy schedule and professional commitments, he's pursuing endurance sports like cycling, trekking, and marathon running. Over to you, sir.
Thank you. Can you hear me?
Yes, sir, we can hear you.
Okay. So I'll start. Okay. So my talk is about trifocal IOLs. I don't have any financial interest in any of these lenses, what I'm showing. This is just to understand the philosophy of these lenses. So patients, they want emetropia with good distance, intermediate near vision. That is current day's demand. And there comes the role of premium IOLs. So few things, some limitations, some cautions one need to understand that multifocality by its nature, it's an optical compromise. So it's a trade-off for 2 or more focal points on the retina. And that these lenses are going to give you some halo and glare, as well as some reduction in contrast of the light. Along with that, capsular problems like PCO, fibrosis, some decentration can affect quality of the vision, as well as corneal astigmatism in the long term keeps on changing. That can also affect long-term stability and quality of vision of these lenses. So whenever you think about premium lenses, it's all about patient selection. So unless and until you understand your patient, select your patient properly, as Dr. Sujata had already mentioned, that you need to select your patient properly. So spend some time with your patient, understand his needs, what occupation he is into, as well as what he expects from this lens and what you can deliver to him. So be frank enough, don't promise him very big things that you'll get rid of your distance near and intermediate problems with these lenses. One may have to have some kind of a drawbacks also. So what patient expects from these lenses and what you can deliver, one should be very clear about. Along with that, nature of the patient, whether it's a type A personality, very demanding kind of person, as well as age of the patients and his morbidities. So whenever you come to investigations, you need to check eye properly. You need to all have big number of gadgets to understand whether a patient's eye is healthy or not. So more the healthy eye, better the result. So check for his cornea refractive status, whether hyperope or eye myope and all this thing. Check for astigmatism. Along with that, any aberrations in the system and cornea. Check for angle kappa or alpha. These patients are very sensitive for angle kappa more than 0.3 or 0.27. And what pupil size patients have, if patient is young, you have to see how dynamic his pupil is. And if patient is very old, you need to see whether at least his pupil diameter is about 3 millimeters. Check for status of macula and optic nerve. Check for ocular surface disorders and dry eye, as well as endothelial cell count. Do proper power calculation of these lenses. Use your own A constant. Use good optical biometers. And have a backup plan in case patient is not satisfied or you need to undertake any kind of a treatment like correction of astigmatism or some spherical error or some kind of problem like capsulotomy or dryness of the eyes and all these things. So backup plan must be ready with you, and you should explain it to your patient as well that you may need some kind of treatment in the future if at all some cylinder is left with or some treatment is required. You need to definitely show your patients what kind of problem he may see, that is about glare and halos. So you may show him this kind of a card so that patient gets clear idea about limitations of the technology. Or this is kind of a glare simulator. This is it may be either none or mild or moderate. Okay, so patient gets some imaginary idea what can be expected with these lenses. So coming to basics of this multifocal IOLs, as Vaishal has already explained to us that technology started with refractive lenses to diffractive, then combination of refractive and diffractive, and ultimately it's a true multifocal solution. Coming to difference between refraction and diffraction. Refraction is an optic when optic meets with a smooth continuous surface and bends the light to a single focus, that we call it as refraction. Whereas in diffraction, optic surface that contains some physical steps that divides light into near and distance and forms two images on the retina. So diffraction steps on the lenses, it has got some principles that shorter the step, higher is addition, and wider the step, small is addition. Whereas high step, it brings more energy for near, and wide step brings energy for distance. Here comes the role of apodization as well. So variable step height from center towards periphery, that is what intelligently used in restore lens. To sum up, the three different type of lenses, that is earlier models were zonal refractive lenses, that's AMO array lens. It had 5 different rings of distance and near, alternatively arranged. But there is a hollows and glare problem was very severe because of the start and end of this ring. One gets a lot of glare and hollows with these lenses, so these lenses are no longer being used. The next generation lenses, that is full diffractive lenses, it divides some amount of light energy, 50% for distance and near, but these lenses also give some kind of a hollows. And apodized diffractive lenses, what is being used in Alcon Restore, in which the small 3.75 millimeter zone, that is a diffractive zone in the center, while as peripheral lens is like any other aspheric lens. So in the darkness or in the nights, total energy is shifted towards the distance. So step height gradually decreases from 1.3 to 0.2 micron these lenses, and amount of energy that goes almost 22% in the periphery. So what is the difference between Alcon Restore and Panoptix lens, which is being recently introduced? Alcon Restore at 3.6 millimeter of diffractive zone and 9 steps of different power, while as Panoptix has got 15 steps and diffractive zone. It is not a apodized diffractive, it is purely diffractive lens. So that diffractive zone is of 4.5 millimeter, and it has got 2 distinct foci. One is at roughly 2.3 at diopters, that is spectacle number, and other is 1.63, that is for intermediate power. So first one is for near and other is for intermediate power. To understand what diffractive principle and focal points are seen in trifocal technology, which is conventional, it has got 2 distinct foci. One is 40 centimeter, other at 80 centimeter, and remaining amount of light is given for distance. While as in quadrifocal technology, what Alcon claims, it has got 3 distinct foci, one for 40, other 60, third one is 120, and remaining is for distance. But this 120 centimeter focus, it is so arranged that that amount of energy it is added for distance, and in fact you get only 2 foci. There is one for near 40 centimeter, and there is quite nearer to it, that is 60 centimeter. So it gives a one continuous depth of focus from 40 to 60, which is good enough for reading and for a computer or laptop. While as at Lisa lens, it has got 2 distinct foci. One is at 40 centimeter, that is for near, other is for 80 centimeter, that is for intermediate vision. So in Alcon Panoptix, that is called as the enlightened technology, that 1 centimeter zone merges with the distance zone. So almost it transmits 88% of the light at 3 mm pupil size to the retina. So for bigger pupil, almost most of the energy is directed towards distance, while as near and intermediate foci, they get remaining amount of vision, that is 50%. Coming to other lens, that is at Lisa lens, they have 4 models, and the most common one, that is at Lisa trifocal lens. This is a plate haptic lens of 6 mm diameter, and overall diameter is 11 millimeters, while as these lenses are hydrophilic with hydrophobic coating. But basically these are hydrophilic lenses. This lens is available in toric also. So typically near vision AD is of 3.33 and intermediate AD is of 1.66. Zeiss claims that it has got a feature of SMP technology. SMP technology means smooth microphase technology, which means that the steps, they do not have any right angles or sharp edges, and which guarantees that optical image quality doesn't suffer any scattering, and still it maintains the diffractive advantage. When you look at the Air Force resolution target with this lens at 3 different distances, you can see for far vision, intermediate, near vision. So it's a asymmetric distribution of light in these three places, but fairly good to see this result that far vision is much clearer, intermediate vision gets distance gets little less light, but near vision gets good amount of light. So it's a asymmetric distribution of light in these lenses. So there is a concept of LISA, that light is distributed asymmetrically. Okay. So division is 50, 20 and 30. 50 for distance, 20 for intermediate and 30 for near. It's independent of pupil size since it's a diffractive technology, and it has got SMP technology, so it reduces light scattering. And this lens has got negative asphericity of 0.1. So to compare all these lenses, whatever currently these 2 lenses I know about, and one more lens of Acri, this IOCare, they have a tri-dip lens. It's on the similar principle like at LISA lens. So typically these lenses, Panoptix has got a non-apodized diffractive surface, while as fine vision PhysioL, it has got an apodized diffractive surface, and at LISA it is non-apodized diffractive surface. The refractive zone is 4.5 in Panoptix, whereas it's 6 in these 2 remaining lenses. And it has got a light energy distribution of 50, 25, 25 in Panoptix, whereas it's a 50, 20, 30 in at LISA or fine vision lenses. And total light relation, they claim it's 88% in Panoptix at 3 mm aperture size, while as fine vision and at LISA lenses, they almost have 86% of light available to use. And focal points, Panoptix has got a 40 and 60, while as at LISA has got 40 and 80. And all these lenses are aspheric lenses and having 0.1 asphericity. So coming to comparison of visual outcomes with implantation of trifocal versus bifocal intraocular lenses. So what is this? Is a meta-analysis of more than 317 papers published so far. So it shows that trifocal IOLs provide a better intermediate vision compared with bifocal lenses, and especially for at LISA group. While as remaining, all the things remain same, that near and distance visual performance, spectacle independence, contrast sensitivity, post-operative refraction, and surgical satisfaction is as good as like bifocal lenses. And thank you.
Thank you so much, sir. Thank you for your excellent presentation. We really have learned a lot about all these platforms. Now, I would request Shubhangi Pimprikar ma'am to introduce our expert panelist on this platform, Dr. Ajit Hazari, sir.
Dr. Ajit Hazari has done his graduation from KEM and did his fellowship from the LVP Institute, Hyderabad. Sir is a practicing glaucoma, phaco, and refractive surgeon, and I have listened to all his talks on toric and multifocal and many premium IOLs. We are eager to listen to your expert comments, sir.
Thank you. Over to you, sir.
Yeah. Thank you so much for the kind introduction. Thank you so much, MOS and NOA, for inviting me for my comments on Dr. Sharad Patil's comprehensive, fantastic talk. And it was a totally unbiased and a very broad view of multifocal IOLs, and gives us a very clear, balanced picture of what to expect from different IOLs. And my personal experience has been in majority of the times with the Panoptix lens. And the reason why I prefer Panoptix over the other multifocal IOLs is primarily because these are hydrophobic lenses. And we are all very comfortable with the Acrysof model, with the handling of the lens, the insertion of the lens, the way it opens up, and it goes in through 2.2 millimeters. So you have to, there's a downside to the 2.2 that you have to be more careful about the astigmatism, pre-existing astigmatism. And what I'd like to add to the talk is that if your patient has astigmatism more than 0.5, then it's better to tackle the astigmatism when you're considering a trifocal IOL in these patients. The other thing is that the photic phenomena with these newer generation trifocals have reduced, and the working distance is very comfortable for the panoptic series of lenses. So when you're talking about 60 centimeters of intermediate, now if you talk about intermediate vision, you usually say that it is at arm's distance. So if you're talking about 80 centimeters of intermediate distance, that becomes a little too long for the average Indian of, let's say, 5.8 to 6 feet of height. So 80 centimeters would be probably comfortable for somebody who's 6'2", 6'3". And so that's what I've seen work out for my patients in my clinic, that almost everybody is comfortable with the full range of vision for near, intermediate, as well as distance. Compared to the Restore family, I feel the Panoptics gives a much better distance vision, and of course the intermediate vision. What I have also found in this series of lenses is that even in relatively low light, patients are comfortable if they have a binocular implantation of the Panoptics lens. This wasn't seen earlier with the Restore family, where if the room lighting was less, then patients would definitely need extra light. Having said that, for all multifocals and trifocal lenses, you have to be extremely careful about what patient you are selecting for these lenses. So there lies the difference between the EDOF lenses and the multifocal lenses. The multifocal lenses have a lot of restrictions. Patients who have ocular surface problems, retina problems, then who have high astigmatism, if you're not using toric, it's not a good idea to use spherical panoptics or any other multifocal or trifocal lens. So these are the basic things, but they go a long way in being selective about your patients. And because of the nighttime dysphotopsia, the photic phenomena, then patients who are going to be driving a lot at night, especially doing intercity driving, because we don't have any street lights outside the city limits, it becomes very troublesome for these patients. So these are the few pointers we need to be careful about whenever we are choosing a patient for a multifocal or a trifocal IOL. So that's it. If there are any other questions, I'd love to answer them at a later time.
Thank you so much. Good evening. We have with us our mentors, Dr. Anand Deshpande sir and Dr. Quresh Maskati sir also. Thank you so much for joining, sir.
Thank you, madam. Thank you.
Thank you, sir.
Thank you, Dr. Hazari. Thank you so much.
I would like to request Dr. Pandey sir for his expert comments on this platform.
Thank you very much. I have opportunity to use the trifocal, particularly Alcon Panoptics lens, and as mentioned by the speaker and the panelist, this lens excellent, utilize excellent technology of the hydrophobic Acrysof biomaterial and with the good Tehcnis. So once you use the Panoptics toric, then there are minimal chances of rotation, and the patients are very satisfied with this product. Thank you.
Thank you so very much, sir. Thank you.
Dr. Kalyan, in the interest of time, we will move on to the MOS Indemnity program as scheduled.
Yeah. Please.
Should I, are you able to hear me?
Yes, sir.
Yes, sir. Please.
Yeah.
So should I take the mic?
Yes, sir.
Yep.
No, sir.
Welcome to all. MOS has launched the professional group indemnity insurance for ophthalmologists because the change in the Consumer Protection Act 19, because the limit of the damages to be ordered by the court was increased more than 1 crore. And so there was a need of indemnity insurance to be taken by the doctors more than 1 crore or at least 1 crore. The amount of money which is required for that premium is more than 23,000. Because of this, we have brought, because in the group, we have, with the help of ICICI by Lombard, we brought the insurance premium to 6,490, which is very suitable and easy to pay. We are saving the money of the MOS members, and we also included 10% of the increase in the premium with the staff and 25% for the refractive surgery. The target given was at least 200 members, and we have completed that target. I am very thankful to all, and we have crossed and reached about 300. Now we are handing indemnity insurance documents first to our senior members and to junior members, and with the hands of Dr. Parikshit Gopte, our
Thank you,
MinIOL
sir.
president.
Thank you. This
And
is something that was a brainchild of Dr. Sunaina Malik ma'am and Dr. A. Deshpande sir and Vardhaman. And we have been very, very happy to carry it forward. And I would like to felicitate, one of the two of the senior most members who joined in. So we would like to hand over the policy to Dr. Quresh Maskati. And I would
thank you, Parikshit.
Thank you, Maskati sir. Yeah. And I would request Professor Ragini ma'am to hand over the policy to Professor A.N. Kulkarni sir.
Thank you. Thank you. Thank you. Maskati sir, he called you one of the senior most, huh? Please remember
that's because of the whiteness of the beard.
No, sir. All of you are our advisors, and I would request now Dr. Pankaj to hand over the policy to Dr. Tanvi Hardipurkar, one of the youngest to join.
Yeah. Congratulations, Tanvi.
Thank you, sir. Thank you so much.
Tanvi.
Thank you. Hello, ma'am. How are you?
I'm good, Tanvi.
Hope we never use this policy in our lifetime.
Yes. Hope we never use it. And all of this would not have been. Oh, yes. And all of this would not have been possible crossing 300 plus members without the active interest, enthusiasm of our most dynamic secretary, Dr. Shirish Thorat. So I would request that, we can't hand over Shirish a policy because he himself is the pillar of MOS. But we'll have a separate program on this indemnity issue and about financial planning. We have been needling Dr. Kalyan that he must keep the time, which he has been trying. So over to you, Dr. Kalyan, and we get back to the CMA once again.
Thank you.
Thank you, A.
for MOS PGIO. Thank you again.
Thank you, Vardhaman.
Thank you, Dr. Vardhaman.
Thank you. Thank you all the members.
Thank you, sir.
And cooperation for.
Thank you so very much. So now I'll request Dr. Arpit Shah to kindly introduce Dr. Nitin Deshpande sir. So I request Dr. Nitin Deshpande sir to please load his presentation.
Good evening, all. This is a great honor to introduce Dr. Nitin Deshpande sir. Dr. Nitin Deshpande has done his MBBS from JJ Hospital, DNB from Arvind Eye Hospital, Madurai, long-term glaucoma fellowship, short-term fellowship on diabetic retinopathy. Hello.
Please carry on.
Yeah, you are audible. Yeah. Long-term glaucoma fellowship, short-term fellowship on diabetic retinopathy from Arvind Eye Hospital, Madurai. Observership in glaucoma from Bascom Palmer Eye Institute, Florida, US. He is director of Sri Ramakrishna Netralaya, Thane, Navi Mumbai branch. Over to you, sir, for the presentation. Thank you.
Dr. Nitin Deshpande sir will be talking on MinIOL IOLs. So over to you, sir.
So all the eminent panelists and experts, and it is my pleasure to present this talk about SIFI MinIOL EDOF IOL. I started doing these lenses from almost December or Jan last year, and it's been quite gratifying journey with these lenses. We know that we always had problems with multifocal IOLs. Although they give great results, the problem was discrete foci. So you always had to counsel the patients that they have to hold objects at that particular distance to have a best vision. Then there was always the issue of halos and glares, and which required a lot of chair time with the patient prior to surgery and explain him the problems of halos and glares. And then it was difficult for neural adaptation also, as pointed out by previous speakers also. So especially I found that people with psychiatric disturbances, we never knew about their one or two patients can really give you a big trouble, problems to the halos and glares and problems with the lenses. So this is a new technology. Within central 3 millimeters. It provides extended depth of focus at all focal distance. It's a very extended range under both photopic as well as mesopic conditions. And the peripheral section beyond 3 and 6 millimeters is spheric, and it gives a good distance vision at in mesopic conditions. So this is how the lens looks. It's a and it has got 3 zones: the central zone of positive spherical aberrations, followed by intermediate zone of negative spherical aberrations, and followed by the most peripheral and you can see this interplay of different range of near vision. You can see there are multiple foci created aberrations. Articles on these lenses still because they're under lockdown.
Dr. Deshpande? Dr. Deshpande?
Yeah, yes.
Sir, yes. Probably the bandwidth is not great at your end. So could you just switch off the video so that we can hear your voice more clearly?
Switch off
the video and continue the PPT.
Yeah, is it better?
Better.
Much better now.
So
thank you.
Yeah. So analysis of total. So the analysis of Zernike showed that there was in MinIOL the levels of 4th and 6th order aberrations, which basically relate to the primary and secondary spherical aberrations, decreased slightly as pupil size increased. Now, this was the first IOL in which spherical aberrations actually decreased with increasing pupillary size, because we generally expect aberrations to increase when pupillary size goes up. Even higher order aberrations also decreased with increasing pupil size. So this was a pretty pupillary independent, pupil size independent lens, and I think this was the only lens that we can use when the corneal aberrations are out of physiological range. And I have experienced that myself, because I'll share a video that I have used it in a couple of post LASIK and post RK eyes with great results, where I would be a little skeptical using multifocals. Another point with these lenses is if your cornea is prolate, you tend to get a little better near vision. So because of this additive effect of prolateness of cornea with the aberration profile of the lens. So it works really well in prolate and hyperprolate corneas, while when you're putting it for flatter corneas, oblate corneas, you have to be little careful, especially when you're doing LRIs. Sometimes it negates the EDOF effect of your IOL. So you have to plan that very meticulously. Now, regarding axial length and pupil, now again, this lens is little immune to the effective lens position. We know that multifocals are quite affected by the effective lens position, but this lens works equally well in short voltage. Weak eyes, you can still confidently put these lenses and not worry a lot about effective lens position. The near vision was not influenced by pupillary size as well as pupillary decentration, and this decentration did not affect any contrast sensitivity or best corrected visual acuity. Now, patient selection is very, very important. You have to give a good chair time and explain the patient that they may still have to use a reading power to read even if they have a EDOF. So it's very important to tell all this before surgery is done. We are very, very meticulous doing pre-op workup. So I will share one of my patients ahead. So again, these lenses are very good for older age group where there is an early macular degeneration, because we know that multifocals can reduce contrast because they absorb some, they don't pass a lot of light because of their multifocality or rings or a diffraction on them. But this lens, the light transmission is very high and the contrast sensitivity is great. So you can use it when there is an early macular degeneration. And as I will share my small case study, I started basically using these lenses when multifocals were contraindicated. That is my early glaucoma patients or early diabetic retinopathies, post RK.
Can somebody from Entor tell us whether we have lost Dr. Deshpande's connection? Atharva?
Sir, he is there.
Okay.
He's there, but...
So he can talk without us seeing his screen? We can discuss?
Can you hear me? Can you hear me, please?
Very...
Can you hear me?
Not very clearly, though. Yeah.
Yeah. Hello. Hello.
Yeah, we can hear you. We can
yes,
see
sir.
the slides.
We can see.
We can see the slides.
Am I audible?
Yeah, you're audible, sir.
Yeah. So these yeah, and when I do these lenses for emetropia and non-dominant eye, I go for a little micromonovision of -0.5. So this is my patient. You can see on the left, this patient had an early epiretinal membrane. And so I thought of doing a MinIOL rather than doing a multifocal. And on the right side, you can see what result I have achieved. In right eye, she's 6/6 unaided and little micromonovision in the left eye of 0.5 and a very, very happy patient. We are very meticulous in workup. You can see I do a lippy flow for all these patients to first check their ocular surface. If ocular surface is not good, we make a priority to treat that first. I use a True K Barrett formula on Almaster 700, and that especially in MinIOL, initial results we found that if you want to achieve emetropia, you have to target plus 0.5 diffraction, and in a dominant eye, and in non-dominant eye, when you want minus 0.5, you have to target emetropia according to the Almaster printout. So you have to go little plus 0.5 to achieve emetropia in these patients. Then we do topography routinely. Now, topography also gives us a clue about ocular surface and gives clue about any other related corneal pathologies. Now, there was a study by Savini et al. That all the patients could read at 140 words per minute, which is a very fast speed, and a multifocal can generally give you around 100 words per minute speed. Now, when compared with a monofocal lens, the EDOF, the results of this defocus curve were comparable to the monofocal IOL for distance vision. The quality, contrast, everything was at par with a monofocal IOL, and in fact, in few studies, it even the halos and glares were even lower than monofocal IOLs in one study. And the curve or the defocus curve of MinIOL was progressive, and there was no gaps at the intermediate distances like multifocal lenses. Now, monocular defocus curve maintain acuity of better than 6.9 between 0 to -2 defocus. Monocular contrast sensitivity was normal in all spatial frequencies, and objective assessment of halos, there was a minimal disturbance of halos, glares, and starbursts. So this is our patient that I mentioned prior, and you can see that between a defocus of plus 0.5 to -2, patient has maintained excellent visual acuity, and this is a very satisfied patient. And when you compare the defocus curve of MinIOL with a Panoptix and 80 of a MinIOL. Glares and design network, we recently got hold of it, so I don't have many patients to quote, but according to this study, halos were essentially absent and glare occurred only at very low light conditions. There was a detailed study by Dr. Offar regarding this, that halos and starbursts were less common among patients implanted with MinIOL compared to other lenses like Panoptix and Symphony, and even compared to monofocal IOLs according to his study. So halos and starbursts were absolutely minimal. Then among 14 patients implanted with MinIOL, 50% reported of no halos and no starbursts at all, 30% occasional halos and 22% starbursts. However, when you compare this with a group of Panoptix and Symphony, almost all patients complained of halos and starbursts. So this lens performed much better compared to these lenses. Now you can see actually the chart where you can see that MinIOL has performed far better than Symphony and Panoptix and even monofocal at some levels, and this is a very useful software. We recently got hold of it and plan to do further studies on this software. Patient satisfaction was very high, that 78% could perform their usual activities without spectacles. 71% would recommend to their family and friends. Distance work was absolutely no problem for almost all patients. Only 28% said that they could read newspaper without glasses, and 35% could read books without glasses. So it was necessary to tell patients prior that they may need some ad to read, even if they are opting for this IOL. Just to show you one small surgery.
Dr. Deshpande, can you please?
This is a. Yeah. Yes.
Can you please sum up the.
Yeah. So okay. So this is a small RK case, and okay, I'll just. This is a routine surgery, and this was a post RK case which went very smoothly. I just wanted to show you the lens implantation, which was a preloaded lens and goes in very smoothly. I think I'll just skip this video and go ahead. So this was a study of 29 eyes where 9 were torics and 20 non-torics. Mostly I used these lenses when I did not want to use multifocals, and you can see I had angle closure glaucomas, open angles, RK patients, diabetic retinopathy patient, and one uveitic cataract patients, and all of them did very well. Now I clubbed the result in some groups. So the blue was for distance, then intermediate and near. Near I took to be N6, N8. The intermediate, I included patients of N10 and distance 6/6. And you can see 1 month post-op, very high percentage of my patients were doing very well. And you can see the near vision. Many of them achieved N6 unaided, which gives says that it is such a good EDOF. There were hardly any residual refractive errors. There were very few little minus which we had purposely done a micro monovision. And first few cases where we did before we optimized our IOL constant. So most of them achieved a very, very good emmetropic distance, intermediate and near vision. And you can see that there was hardly any residual power because of very meticulous pre-operative work. So it is a great lens. It gives high performance of visual acuity at all distances, high performance of contrast, negligible halos and glares, high light transmission efficiency, improved reading speed, and very easy to adopt neurally. And it's a very easy to implant lens with the preloaded system. One of my patients, I just broke a haptic while implanting. It was a toric lens, but because of its design, I did not have to explant, and the lens is very stable. So it's a very good lens design also. So thank you very much. Thanks for your attention.
Thank you, sir. Now I request Dr. Arpit Shah to please introduce the expert panelist, Dr. Pandey, sir. Dr. Arpit, please.
Yes.
Dr. Suresh Pandey sir has an MS Ophthalmology from PG IMER Chandigarh, anterior segment fellowship from USA and Australia. Currently Sudi Eye Institute, Kota. He has over 100 journal articles, 12 books, and 20 book chapters. He has done over more than 20 live surgeries. He has achievement award by the American Academy of Ophthalmology. He has received gold medal twice by IIRSI, Best Video Award by AO, ACRS, and ESCRS. Over to you, sir. We are eager to listen to your expert comment. Thank you.
Thank you very much. At the outset, I would like to thank Maharashtra Ophthalmological Society and Nasik Ophthalmological Society for inviting me to join on today's wonderful webinar on the IOL technology. And the speaker, Dr. Nitin Deshpande, has discussed in very detail and shared his experience on the CFI MinIOL intraocular lens. He shared the pearls for successful lens implantation, as well as how to achieve great visual outcome in difficult scenarios such as radial keratomy, post-RK cases, and diabetic cases, as well as in glaucoma cases. So indeed, he explained very nicely about the technology which is utilized in the CFI MinIOL lens. We started using implanting CFI MinIOL intraocular lenses in the month of June, and so far we have done 40 cases of CFI MinIOL intraocular lenses. Out of 40 cases, 28 are the routine cases, and the 12 historic CFI MinIOL lens. And we have done implantation in some developmental cases, white cataract, and as well as in small eyes, and one case post-RT case as well, and post-LASIK also. And one of the most important aspect of this lens is that this lens provides an excellent visual outcome, excellent contrast sensitivity, and the excellent reading speed. Most of the patients are satisfied, extremely satisfied with this lens compared to other lenses which I have done so far, like the trifocals, etc. And the reading speed, even in the normal room light situation, is excellent. So far, the maximum follow-up which I have is 6 months. So there are no PCO in 6 months time, but one of the important aspect to observe is the PCO. And in 6 months, I have not seen any rotational, any rotation in the toric group as well. And more than 95% cases, they achieved 6x6 vision, excellent intermediate vision, and wide range of vision after implanting this lens. The distance vision is also very good. So this CFI MinIOL EDOF lens is perhaps is one of the most exciting lens for the future. And at present, many surgeons are using this implant, and many surgeons are still waiting to try this implant. So my suggestion for all the audience that you can, if you have not tried this lens, please do try this lens. And this is one of the most exciting development in the field of ophthalmology and intraocular lens technology. So I want to thanks again Dr. Nitin Deshpande for excellent presentation and for sharing his experience on MinIOL lens. Thank you very much, Maharashtra Ophthalmological Society and Nasik Ophthalmological Society. Thank you.
Thank you, sir.
Our teacher, our mentor, Dr. Padma Shri Dr. Lahane sir has just joined. We welcome you, sir.
Welcome, Lahane sir.
Thank you, Kalyan. Thank you very much. Thank you very much. Thank you.
Atul Sonawne sir is also there. Sharad Patil sir is also there.
All Nasikkar and MOS. Good evening to you all.
Good evening, sir.
Dr. Pandey sir is also there, sir. Dr. Pandey sir. Dr. Hazari.
Yes. Hazari is there.
So, with your permission, sir, shall I continue?
Yes, continue, Kalyan.
Yes.
I had also wanted to thank Professor Sunaila Malik ma'am, who had started the PGIIO scheme. We were supposed to have a felicitation at her hand, but in your this of trying to keep the time, we just skip that. So go ahead. And it's good to have Lahane sir here.
Great. I would request other experts, Dr. Ajit Hazari sir, to have quick comments on this.
I feel it's an exciting technology that we are looking forward to. And like Dr. Pandey mentioned, that I'm also one of the people who's waiting to use this lens. Okay. There's a lot of exciting talk happening about it. So let's just wait and see.
Thank you so much.
Thank you, sir. Dr. Aditya, would you like to give your expert comments?
Like Dr. Hazari sir just said, we are really excited to have this lens in our hands very soon. Hopefully, it will prove its worth.
Okay.
Thank you, Dr. Aditya. Dr.
Thank you so
Lahane
much,
sir, would you like to say something about the newer lenses, newer technologies, and whether we should use all the newer lenses or what we should do? What is your opinion, sir?
I have heard Dr. Kenya last time when he was discussing about this new lens. And I think what they are saying, unless and until we use that lens, but what saying it look good. Whatever we hear, it is definitely a good lens. And if it comes to us, then we will use it. And how the patient reacts. If the patients are happy, then we are happy. If the patients are unhappy, then that time, so many lenses came. Every time when the lens is coming in the market, then the company is having big bazaar that yes, the lens has came. And after that, gradually that goes down. So now this lens is also coming. So we must see, I always say, we must welcome the change. We must welcome the innovation. Unless and until we welcome, because one day we are fighting that SICS is good, our FECO is good. Now we have stopped that. Now we are fighting that FEMTO is good, our FECO is good. It means FEMTO has came. It means gradually there should be, I think, new innovation, new things should come in the ophthalmology. And I think all the researchers, I salute them. Because of them, we are, I think, getting new and newer things. So I think that is a very good thing. I wish you all the Happy New Year, healthy New Year, prosperous New Year, and no Corona New Year. Thank you very much, Ragini, and all MOS and all Nasikpur. Thank you.
Thank you so very much, sir. Thank you.
And
thank you, sir.
Parikshit, I forgot Parikshit. And also I want to thank Parikshit, the Thorat, who has made this indemnity scheme, and the Vardhaman and Malik madam. Thank you.
Deshpande sir.
And Deshpande sir. Thank you very
much.
Thank you, sir.
Thank you so very much, sir. I would request Dr. Sharad Patil sir to add his comments on this talk and this platform, CP MinIOL IOL.
As I said, like other speakers, I don't have any experience of this lens, but looks exciting because this group of patients who has diabetic retinopathy, some glaucoma, some RK and all this thing, these patients were really deprived of premium IOLs, and these patients were mostly receiving monofocal lenses only. But this is a new venture, new thing which is coming up, and we should observe how it works in coming couple of years. So it's a good change and good beginning.
Thank you, sir. Now moving on to the fourth talk for today's webinar. Our member, Dr. Sandeep Joshi, will introduce our very own Dr. Manish Bape, who will be telling us more about iHance, new frontier on.
Hello, good evening.
Yes,
am I audible?
Yes.
Yes, Sandeep.
Yes.
Please go on.
Am I? Yeah. It's honor to introduce Dr. Manish Bape, sir. Sir has done MBBS from Kasturba Medical College in 2000. Sir has done a DNB ophthalm in 2003 and fellowship in Vitro-Retina in 2005 from well-known institute from India, Shankar Netralaya, Chennai. Sir has done FRCS in 2006. Sir got many awards and I would like to highlight some of them. Sir got K. Vasant Madhavan Gold Medal for Best Outgoing DNB Student in Shankar Netralaya in 2003. His innovation, the novel IOB forceps, has received Innovation Award of Maharashtra Ophthalmic Society at MOSCON Pune 2017 and Rakesh Sharma Memorial Award in Trauma Session at All India Ophthalmic Associate Conference Coimbatore 2018. This device was extensively used in removal of shotgun pellet from eyes of victim of pellet injury in Kashmir Valley in 2016 and still used extensively throughout the India. His Sir's Innovation Aspiration Scraper has received Dr. S. Natarajan Award for Best Paper in VR Surgery Session at All India Conference Indore 2019. Sir practicing in Nasik as a cataract, refractive and VR surgeon since 2005. Sir has done over 100 presentations at national and international conference. His 7 publications in various peer-reviewed journals. Sir has performed thousands of cataract and vitreoretina surgeries. Sir has performed more than 10,000 laser procedures and anti-VEGF injections for various retinal diseases. Over to you, Manish sir. Thank you.
Thank you.
Welcome, Manish. Dr. Manish will be speaking on iHance, the next frontier in monofocal IOLs. So, Dr. Manish Bapai, please.
Yeah.
Please.
Thank you, Dr. Kalyan, for giving me this opportunity. I would like to thank MOS and NOA for this opportunity to speak. I'll be talking about Tehcnis iHance IOL. There are no financial interest, unfortunately, to disclose. So we are all used to Tehcnis IOLs, Tehcnis 1 IOL. Most of us have used, and we are very happy with it because of excellent quality of vision, high contrast, reduced light scatter, and minimal decentralization because of less capsular phimosis. So the Tehcnis iHance IOL is basically on the same platform as Tehcnis 1 IOL, and but it gives better intermediate vision. Let's have a look at it. It's a refractive aspheric lens, which is based on Tehcnis platform. It has a refractive technology, so there are no rings. It is based on continuous higher order aspheric surface, which so there are no zones. It cannot be distinguished visually from the Tehcnis 1 IOL and has same base geometry. So it has 6 mm optic and 13 mm in the diameter of the lens. It has a squarish design and has spherical posterior surface. It reduces spherical aberration close to 0. It has a higher order A-sphere on the anterior surface. So basically, which means that there is a gradual and smooth and continuous increase in power from periphery to the center of the lens, which gives it a very peculiar profile. It is not based on zonal design or spherical aberration design, as we have seen in previous talks, where the different types of EDOF lenses as well as the the trifocal lenses. The periphery of the lens is identical to Tehcnis single piece IOL, but power increases continuously from periphery to the center without steps or zone. It has negative. It has same spherical. Spherical aberration, that is negative spherical aberration lens of minus 0.27 approximately. Because of the change in the profile from periphery to center, it gives better range of vision from distance to intermediate vision. It gives excellent, as we will see, it gives comparable distance vision to Tehcnis 1 lens also. As I mentioned before, the lens cannot be visually distinguished from the Tehcnis 1 IOL. However, there is gradual change in the profile as here, as we can see. There is a very gradual change in profile of the anterior surface. So this was a very interesting paper in JCRS June this year, where they have actually done contact profilometry of 6 different type of IOLs. And 4 of these are monofocal and 2 EDOF lenses, but we'll look at the 4 lenses of from the Tehcnis family. And here, after doing the 3D profilometry, they have converted into 2D profile representations, and later the best fit sphere was subtracted to see enhance the differences. So on the left side, the panel shows the profile, the 2D representation, where we can see the sensor single piece, Tehcnis 1 IOL, the iHance IOL, and the and their EDOF lens, that is a symphony lens. Here we can see there is a smooth profile which can be seen on first top 3 lenses, which are even with the profilometry, it is almost impossible to distinguish. However, when we negate when we subtract the best fits circle, we can see the change in the profile from sensor single piece to the Tehcnis one, which has this asphericity on anterior surface. And this is a profile of iHance lens, where we can see there is gradual increase in the power, the change in the shape in the anterior surface of the lens. Looking at the implantation, both lenses, they look same, they feel same in implanting the lenses. These are the videos of both lenses. They look absolutely and feel absolutely same to load as well as to implant. There is absolutely no difference that we feel, and I'm sure most of us have used it and have have experienced this. There you go. The lens unfolds beautifully. Yeah. So let's look at the performance of the lens. This was an initial clinical investigation which was done by Johnson & Johnson, where they have implanted that these are the phase 1 and phase 2 patients. There were 61 subjects which were bilaterally implanted with either the iHance or the Tehcnis 1 IOLs. And at 6 months visits, the 67 subjects of iHance and 72 subjects of Tehcnis 1 were analyzed. The primary endpoint was distance corrected intermediate visual acuity, best corrected distance visual acuity, and uncorrected intermediate visual acuity were the secondary endpoints. So what it basically found was that Tehcnis iHance IOL provides statistically significant improvement in binocular intermediate vision as compared to the Tehcnis 1 IOL, which is statistically significant. The binocular distance vision is comparable with Tehcnis 1 IOL. And in low light, low contrast condition, the visual acuity is still 20/20. As compared to the other monofocal IOLs, it gives improved image contrast, and in large pupil also. And there were no photic phenomena that are noted in these studies. The photic phenomena, namely halo, glare, star burst, etc., that we saw in multifocal and trifocal lenses that we have to inform the patients about. Looking at our hospital data, this is slightly older data, but we did retrospective chart review, and we included 25 eyes of 23 patients where the age was between 30 and 75 years, and follow-up was 7 to 30 days. None of the patients complained of any photic phenomena at all. The majority of patients had distance visual acuity of better than 6/9, that is uncorrected visual acuity. Intermediate vision in about 70% of patients was 6/9 or better. And the intermediate vision Snellen's equivalent was 20/32. Let's look at one of our patients' experience that she shared with us.
we can't hear her. You can tell us her comments.
Yeah. So basically, this is one patient who's telling us that she has undergone bilateral iHance lens, and she only needs glasses to read very small letters at reading distance. Otherwise, she doesn't use glasses at all. So basically, intermediate vision is required for most of our activities, like cooking, looking at laptop, looking at tablets, etc. And this lens definitely gives much better intermediate vision as compared to the usual monofocal lenses. This lens is not classified by the company as extended depth of focus lens. It is they call it as a modern day monofocal IOL because it looks and feels the same, but it gives a much better intermediate vision as compared to currently available monofocal lenses. So to summarize, I think this is a revolutionary lens which is not very expensive, which gives very good vision. And in my personal experience, most of the times patient is able to read N6 even with +1 or +1.25 add, while the rest of the activities they are able to do without glasses. Excellent for patients who are who are high strung, who have need for night driving. At the same time, they have majority of their activities at intermediate distance. Thank you again for this opportunity.
Thank you, Dr. Manish, for that excellent overview about the iHance. Now the expert comments would be from Dr. Aditya Kelkar. Dr. Sandeep, our NOA member, will introduce Dr. Aditya Kelkar. Dr. Sandeep, please.
Yeah, good evening, everyone. Dr. Aditya Kelkar sir is director of NIO Pune, which is NABH and JCA accredited PG Institute. Sir got gold medal award during his MS tenure, and also he is a gold medal awardee during his DNB tenure. Sir is recently awarded with American Retina Honor Award of prestigious Rees Buckler Award, and also got best paper at Asian Pacific Academy of Ophthalmology. And also sir is recipient of IJO Gold Medal Award. Sir honored with gold medal by Implant and Refractive Society of India. Over to you, sir.
Thank you for your introduction and excellent presentation by Dr. Manish. He probably explained everything in details about this newer monofocal implant. So I would probably put this monofocal implant into its own perspective. What I feel is nowadays the patient's depth perception has to be better because of the activities that patients undertake. For example, simple activities such as cooking or walking down the stairs is very difficult using those bifocal glasses. And especially this lens, iHance lens, which is very useful for an intermediate work, such as cooking and also walking down the stairs. So these are practical difficulties which many of the patients with conventional monofocals have been facing. And these difficulties can be overcome potentially with the help of the iHance IOL. We've also seen that some of these patients also require lesser near addition. Some patients are happy even with +2 or +1.75. Although it's not the same thing that we experience in all the patients, but yes, some of the patients do report to us that their near add has also reduced. So it has a great potential, I feel, this type of technology, and it offers a good driving pleasure, I would say, for patients who do not tolerate multifocal IOLs. So it's something in between where patients don't have to pay too much of a price of a multifocal IOL and still derive some of the advantages of multifocal. Thank you.
Thank you, Dr. Aditya. I would like to invite comments from Dr. Patil sir. Sir Patil sir, please.
Dr. Pandey sir till Dr. Patil sir. Yes, sir.
So iHance is one of the excellent lenses for people with modest expectation from lenses. It definitely gives a bit better vision for intermediate distance, like 1 meter or so. And if you can mix and match this lens one eye for a dominant eye for distance and just keep other eye a little myopic so they can even see to the distance of computer or some mobile also they can watch with this kind of lens. And it's one of the very good lenses. I have been using it since a long time and quite happy. Patients are also happy with this lens. And like other multifocal or EDOF lenses, it doesn't have any dysphotopsias. And it's one of the very good monofocal lens if one want to choose.
Thank you, Patil sir.
Thank you, sir.
Now I would request Dr. Suresh Pandey sir to have his expert comments on iHance.
Dr. Manish has very nicely explained and shared his experience about the Tehcnis iHance lens, and as he rightly mentioned that this is modern day lens, or you can say monofocal. We are just entering into monofocal plus lens era. And in my experience, this is one of the very cost-effective and wonderful lens. Patients are very satisfied. Most of the patients, the intermediate vision is very good when you have done bilateral implantation, and most patients are very happy and very satisfied with this technology. So this is one of the most preferred technology which we are using nowadays, and most of the lenses, for example, we were implanting Tehcnis monofocal. Now we are, providing the benefit of iHance lenses to those cases also. Thank you.
Okay. Thank you, sir. Now I would request Dr. Hazari sir to his quick comments on iHance.
I'm sorry, I have no experience with the lens.
I see. Okay, sir. Thank you so very much. Now we'll be moving on to the question answer and panel discussion.
Kalyan,
yes, sir.
Before we go for question answer, I just want to make a small announcement.
Yes, please.
Our respected Dr. Tatirao Lahane is contesting for All India President's post, and all of us from Maharashtra and Nasik, we do support him, and I appeal to all of you to promote his name, give him support, because he's one of our most prestigious teachers, doctors, and he has done a lot for ophthalmology, and I hope that every one of you spread the word for him.
Yes, sir.
So, if you hooray for Dr. Tatirao Lahane.
Thank you, sir.
Sure.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you very much.
Thank you.
We will spread the word in Rajasthan also.
Yes, thank you so
Thank you,
much.
Pandey, sir.
Thank you, sir.
So are there any questions coming, or I think it was a fantastic discussion.
Yeah.
So Dr. Kalyan, Dr. Sonavne, should we continue, or I think we can wrap up? Dr. Pandey, sir, Dr. Lahane, sir, Dr. Patil, sir, Vaishal, Dr. Nitin,
Unless someone has
Dr.
got
Hazari, sir.
It doesn't look to have any questions here in the chat box. There are no questions.
No, and the speakers have been very, very detailed and have explained it very well.
Yes, yes.
it was a good interaction and good to know some of the new lenses also. And thank everyone for a wonderful presentation.
I think there are no questions. So there was, all the presentations were so excellent and comprehensive that I know all the delegates and all the people who have attended got an excellent value out of it. And most of the delegates will definitely look forward to use these lenses in their practice after listening to all these excellent talks. I would now request our Chairman Scientific Committee, Honorable Dr. Ragini ma'am, for her comments. Please, ma'am.
Padma Shri, Dr. Lahane sir, my teacher, Dr. Parikshit Gopte, the president of MOS, Dr. Suresh Pandey sir, Dr. Ajit Hazari, Dr. Aditya Kelkar, Dr. Sujata madam had to leave because she had some urgent meeting. And the whole of Nasik Association with their mentors, Dr. Swati Zamwar and Manish as the scientific committee members. We call ourselves as five, Sirish, Pankaj, Swapnesh, And, I think Kalyan and Dr. Sonavne with their whole team did so well in arranging this and took so much effort, so many phone calls, even planning this minute-to meeting. I think it was so well conducted with seniors like Sharad Patil sir being there at Nasik, and our speakers, Dr. Vaishal, Dr. Nitin Deshpande. I know them for so many years. They are from BOA, and I think it was such a beautiful amalgamation with such beautiful comments coming from the panelists, and a very, very well conducted meeting, Dr. Kalyan. Nobody would think that, he was so, I told him that he would do it so well. I thank you everybody on behalf of Dr. Parikshit. And I really thank Dr. Sharad Patil sir for how well he spoke about Dr. Lane sir and Dr. Pandey sir for cheering us up like this. Thank you so much, sir. Once again, Dr. Kelkar, Dr. Aziz Hazari, thank you for being with us.
Thank you so very much, ma'am. Now, I would like to thank President MOS, Dr. Parikshit Gokte sir, for giving us this opportunity. Chairman Scientific Committee, Professor Dr. Ragini Parekh ma'am, for putting trust on us to conduct this program. Secretary MOS Dr. Shri Thora sir for all his guidance all the time. Padma Shri Dr. Lahane sir for his valuable guidance and trust. Thank you all the speakers, Dr. Vaishal Kenia sir, Dr. Sharad Patil sir, Dr. Nitin Deshpande sir, Dr. Manish, our very dear friend, for their excellent and comprehensive presentations, giving so much of excellent insights of about all these newer technologies, which I think most of the MOS members who have attended the program has got, and they are now encouraged to use these lenses. And the comments from the panelists were so excellent and comprehensive. To have more insights about it, Dr. Sujata ma'am, Dr. Ajit Hazari sir, Dr. Suresh Pandey sir, Dr. Aditya Kelkar sir, thank you so very much for your contribution. And our very own team, Dr. Atul Sonane, our dear president, Dr. Swati Zawar ma'am, who has been through the program. She is all the time guiding us. Dr. Shubhangi Piprikar being the co-chairman of this program. So all our NOA team, thank you so very much. And most important, and the last part, the ENTO team, Mr. Raman, and, Mr. Raman, Mr. Athura, and all his technical and all the team for all the support.
All of them.
Yeah, to make this meeting happen and giving such an excellent platform.
Yes,
so thank you so very much.
Very helpful.
Thank you to all of you.
Thank you so much, Dr. Kalyan. Thank you.
Good night.
You've so nicely thanked everybody, every single person. Thank you so much.
Yes. Thank you, Kalyan.
Thank you.
Apart from this,
Shirish sir.
No, apart from this, I must thank Parikshit and our guiding force, Ragini madam. My closest Pankaj and Swapnesh, who really takes a lot of efforts to make every CME successful. Thanks a lot. This is from my end. Thank you.
Thank you. Thank you so much. Thank you. So well conducted, Dr. Kalyan, Dr. Atul, Dr. Manish, Dr. Swati, Dr. Shubhangi. Thank you so much. Thank you so much, Dr. Sandeep. Thank you, Dr. Vaishal, Dr. Nitin. Thank you, Dr. Pandey sir, Dr. Hazari. Thank you so much, Dr. Aditya. Bye. Thank you. Good night, everybody.
Bye. Good night.
Hopefully, with Corona, we will meet personally and not only on Zoom. Thank you so much.
Thank you. Yeah. Thank you. Thank you. Thank you all.
Kalyan sir, very good saying. Thank you.
Thank you, sir.